I'm Dr. Ganga Shankar from Hyderabad. Ellariki namaskara ಮತ್ತೆ ಹೃದಯಪೂರ್ವಕ ಸುಸ್ವಾಗತ. I love to speak in Kannada after my mother tongue Telugu. Thank you very much. Thank you Harish sir. Thank you ISCP for giving me this opportunity.
We should not understand.
Everybody understands. So as sir said, 40% of your practice comprises of proctology. So you should know anatomy very well, understand the physiology, then only you can wisely apply the treatment options. This is not the anatomy which is taught in our books. This is just anatomy related to your diseases and treatment options. So look into the picture. Rectum is a tubular structure. It is a tube-in-tube concept. There is an inner tube, there is an outer tube. Inner tube is S-shaped or concave or convex. It is a visceral compartment. Comprises of mucosa, submucosa, internal anal sphincter and longitudinal muscle. There is a funnel-shaped outer tube, consists of levator ani and external anal sphincter, supplied by the pudendal nerve. This is skeletal muscle. The inner tube fits into the outer tube. The overall shape of the anal canal is like this. So let us see inside what is there. There is a surgical anal canal and anatomical anal canal. The anorectal ring formed by puborectalis, longitudinal muscle, external anal sphincter and internal anal sphincter. This is also known as Hermann's line. So surgical anal canal extends from anorectal ring up to the anal verge. It is approximately 4.4 centimeters, a little larger, longer in females. The anatomical anal canal extends from dentate line up to the anal verge. For all the practical purpose, we will be dealing with only surgical anal canal. Let us see how it is divided. It has divided into three parts. There is a upper area, mid area, lower area. Remember, it is not upper 1/3, mid 1/3, lower 1/3. It is upper area. So upper area extends from anorectal ring up to the dentate line, approximately 2 to 2.2 centimeters. From the dentate line up to something called as Hilton's line, white line of Hilton. This corresponds to intersphincteric groove. This is also known as Jackson's groove, approximately 1.8 centimeters. And lower area, all of us knows, this is the anal verge area. Look into the picture, upper area. The ampulla enters into narrow anal canal. That is the reason we have the foldings of mucosa known as columns of Morgagni. The lower end, each column is connected to each other by means of walls of Morgagni. Into the concavity of walls, there are the intraepithelial openings. These are known as the crypts or sinuses of Morgagni. All I will show in video. Let us see epithelial lining. The distal rectum or surgical anorectal ring area, it is columnar epithelium and pink in color. When one moves towards the dentate line, approximately 0.5 millimeters to 1 centimeter, this is arrow shows this is anal transition zone. The epithelium gradually transforms from columnar to cuboidal in nature. Below dentate line, it is a squamous epithelium, non-keratinized epithelium, no hair follicles, no skin appendages. And anal verge is lined by true keratinized squamous epithelium. The only difference between the anal verge and perianal skin is more corrugated and more pigmented. I said anal transition zone. Here specialized receptors are present. These are known as genital corpuscles, free nerve endings. What is the surgical importance of this area? We know during the defecation something called as sampling reflexes. The sampling reflex, because of this reflex, somebody has said rectum is more intelligent organ next to brain. The rectum able to differentiate your solids, flatus and liquids. And whenever the conditions are unfavorable, we can retain the feces. And whenever the conditions are favorable, we can excrete. If you damage this area, tomorrow you may be doing Milligan-Morgan or stapler hemorrhoidopexy. This discrimination will be lost. That is the reason you have the low anterior resection syndrome following the colorectal colonic resection, and following the removal of this area, if you do the extensively Milligan-Morgan, you will have the incontinence. The patient is not able to differentiate between these two. And we should preserve for all the practical purpose this area, and especially in patients with IBD and IBS. This is a white line of Hilton, dentate line. Between these two, you can see the anodum. There is a fissure. From dentate lane, approximately 2 to 2.2 centimeters. From anorectal ring, approximately 4.4 centimeters. The anorectal ring can be palpated with the index finger and finger should be hooked. This is an intersphincteric groove known as a Jackson's groove. Above you can see the anal cushions. This is a dentate lane with the crypt. Above is the anal transition zone. That should be preserved for all the practical purpose. This video is from Rahate sir. You can see the intraepithelial crypts or sinuses. The surgical importance of showing this video is, this is the area through which the infection goes and perianal abscess forms. So always the sinus or crypt will be at the dentate lane. Always look for your internal opening at the dentate lane only, unless otherwise specified. I welcome Dr. Shanti Madam. She is a treasurer of ISCP. Let us see what are these cushions. You can see in the picture, these are the firm hemispherical structures projected into the surgical anal canal. They extend between the beginning of the surgical anal canal and beginning of the anatomical anal canal. They are essential for three functions. They maintain the continence, they helps in the defecation, and they are essential for maintaining the 20% of resting anal pressure. The cushions are placed in anchored to the muscles by means of Treats muscle. It is a medial fibromuscular extension from the longitudinal muscle, which has got the two components. There is a submucosal smooth muscle, there is a mucosal suspensory ligament. Overall, anal cushions are anchored to your sphincter muscles. This is the same thing shown in the color. This is how it acts as a lips and helps in the defecation. During the defecation, the cushion, they don't change in the length. There is only emptying. During the emptying, they slides down and failure to come back results in the hemorrhoids. This is the same thing shown diagrammatically, where the length of the anal verge may change, but the anal cushion length never changes. This is a histological picture of a cushion. This is a normal cushion. You can see the broken smooth muscle and fragmented Treats muscle, which is the basis for your sliding anal cushion theory. This is the anal cushion. Anal cushion has got the two components. The green color is non-vascular component, comprises of collagen and elastic fibers. And this red and blue are vascular component, consist of arteriovenous communications between the terminal branches of your superior humeral arteriole and venule. This is known as corpus cavernosa recti. Why I am telling? Whatever the surgery you are learning, new procedures like lasers, chivate, all are targeting this area only. This is a longitudinal muscle. It curves around the smooth muscle, internal anal sphincter. This is a submucosal smooth muscle, anchors the entire anal cushion with the help of submucosal smooth muscle to the internal anal sphincter. These arrows are suspensory ligament, which anchors your anal cushion to the longitudinal muscle. You may be learning the laser. The purpose of putting the laser inside the anal cushion is it induces the inflammation followed by fibrosis and repositioning of your anal cushion. This is the basis for non-excisional hemorrhoidectomies. See this picture? The above the levator ani, rectum is supplied by superior hemorrhoidal artery and middle hemorrhoidal artery, below by the inferior hemorrhoidal artery. Even if you ligate superior and middle hemorrhoidal artery, rectum survives on inferior hemorrhoidal artery. Today or tomorrow you will be learning new procedure called as chivates, where you ligate these vessels 2 and 4 centimeter above your dentate line. Even after when I learned 5 years back, I had a doubt why rectum will not get the necrosis, why mucosa will not get the necrosis. This I am quoting from American Society of Colorectal Surgeons textbook. The rectum will never get the necrosis. It will survive on this vessel. See this picture? The vessels has got the extramural course, transmural course, submucosal course. This is the dentate line. This is the point of tip of the laser where you will do the dearterialization procedures for your hemorrhoids. This is a point where you will ligate the vessel for dearterializing your hemorrhoids. These are the various dearticulation procedures: Doppler guided hemorrhoidal artery ligation, finger guided, laser dearticulation, chivates. Whatever the procedure you do, you are ligating vessel either in the submucosa or transmurally. If you are doing the stapler hemorrhoidopexy, it dearticulizes in submucosa, whereas the chivates in the muscle level. This is the anal gland. From the crypt, there will be a duct. The gland opens into a submucosa or intermuscular space. This is a latest concept by Francis Xu Chuan. He's from Singapore. The 80% of the glands are present in submucosa. It is, it is rich in lymphatics. This is also known as anal tonsil. The 16% only pierces your internal anal sphincter and 2% intersphincteric area. Only 1% will reach the crosses the external anal sphincter. Then how does the infection spreads to perirectal spaces? See this gland. It is a racemose type of gland. There are multiple branches. These branches aids in spread of your infection and inflammation. Coming to the muscles, the inner one is a internal anal sphincter, mid one is a longitudinal muscle, and this is the external anal sphincter. How to identify the internal anal sphincter? This is always pearly white in color, and whenever you apply the energy, it will not twitch. This is how you palpate for the intersphincteric groove, and this is how the internal anal sphincter looks. And many people will be having doubt, how much of the sphincter should be cut? If you are doing the sphincterotomy, you can cut the sphincter up to the dentate line. And whenever you are doing the intersphincteric fistulas or supralevator fistulas, you can cut the sphincter. Parks has described up to anorectal ring you can cut. This is the anatomical architecture of the sphincters. This is the internal anal sphincter and external anal sphincter. What is the surgical significance of this architecture? See, we does the sphincterotomies at 3 o'clock and 9 o'clock. Here the internal anal sphincter is very well supported by external anal sphincter. If you do the surgery here, there will be something called as keyhole deformity do occur. And second thing, here the sphincter is least supported at 6 o'clock and 12 o'clock. And blood supply will be less. That is the reason you'll have the fissures at 6 o'clock and 12 o'clock. See the sphincter's architecture in a female. Anteriorly, there is a wide gap between the external sphincter and internal sphincter. This is a male sphincter. This is a 3D perianal sonogram. The gap is less. That is the reason the anterior fistulas in a female are complex. And following the child delivery, following the any perineal surgery, they are easily torn or easily get weakened. That is the reason perineal prolapse and other syndromes may occur following the perineal surgeries, even following your forceps delivery and other obstetrical procedures. This is from old Goliger. This is the longitudinal muscle. This is a very important muscle. It acts as a bone to which the muscles, fascia, everything attached. It gives a various extension. The medial, I have 10 more minutes, don't worry. The medial extension is the treat muscle, and laterally it gives a septa which separates the various perirectal spaces, and inferiorly it forms the corrugator cutis ani muscle, and it divides the perianal space into various compartments. Here there is no space for the expansion. That is the reason perianal abscess and perianal hematomas are painful. See, on the contraction of the longitudinal muscle, the anal opening is widely open. It helps in the defecation. That is the reason it is known as aorta ani muscle. This is a three-level concept of the external sphincter. This is a subcutaneous portion, superficial, and these are deep and levator ani. These are for all the clinical purpose, practical purpose, they are considered to be similar, same. Deep portion of the external anal sphincter is a part of levator ani. The subcutaneous portions are encircles all around, and superficial portion, anteriorly it is related to the transverse perineum, perineal membrane and perineal body. Look at this. Posteriorly it forms the anococcygeal ligament. And this is a very important structure above which there is a deep postanal space. Whenever you are doing the posterior transsphincteric fistulas, you always ask your radialist to look for any infection in this space. This ring should not be divided. If you divide, the true incontinence do occur. This is a cadaveric specimen showing the levator ani and deep portion together, and the superficial and subcutaneous portion. This I have shown. I told how the infection will spread. Embryologically, the muscles, they have the different origin. They are covered by their fascia. If you look at the picture, there are the gaps between the subcutaneous and superficial, between the superficial and deep. There is a gap filled with the loose areolar tissue. Through this gap, the neurovascular bundle centers. Through this gap, the fascia also runs laterally to divide the spaces. Through this gap, your infection spreads from the anal canal to the various anorectal spaces. This is a puborectalis which surrounds laterally and posteriorly, and it is essential for the continence. Whenever it contracts, there is a ventral shift of your rectum, and rectum closes. This is known as a gross anal closure. We should not divide this structure. And usually, there is an anorectal angle 90 degrees. Whenever the defecation occurs, this relaxes, and the angle will become 120 degrees. This aids in the defecation. Let us see the fascia. I said longitudinal muscle, it gives the lateral extension. This is ischio-anal fossa. Ischio-rectal fossa is a misnomer. This fascia divides ischioanal fossa into upper and lower compartment. Upper one below the levator ani known as infralevator space. The lower one is the ischioanal fossa. And from the intersphincteric, from the gap between the subcutaneous and superficial area, this is a transversalis fascia. This is also known as Milligan septum. It separates the perianal space from ischioanal fossa. This is a cadaveric specimen. This has to be opened for draining ischiorectal fossa abscess. This is a Parks ligament, separates your perianal space from the submucosal space. This is also given off from the longitudinal muscle. Whenever your radialis says intersphincteric collection, ask your radialis. There are the three potential spaces between the muscles. Between the internal anal sphincter and longitudinal muscle, there is an inner sphincteric space. And between the longitudinal muscle and external anal sphincter, there is a middle sphincteric space. Any infection from your middle sphincteric space will spread to supralevator abscess. And any infection between your internal and longitudinal muscle, it spreads higher up and it opens via the intrarectal space, and this forms a submucosal abscess. And there is one more space between your external anal sphincter and its fascia. This is the outer sphincteric space. They forms the abscess or fistulas in the roof of the ischiorectal fossa. This is known as the refill fistula. This is the MRI picture showing the inner sphincteric space, middle sphincteric space collection. This is the inner sphincteric space collection. This is the collection inside the fascia of the levator ani. These are known as refill fistulas or Gerg space. Here, if you wrongly interpret ischiorectal fossa, you are unnecessarily opening the ischiorectal fossa and you will make a confined fistula into transsphincteric fistula. There is one more space. Look at the picture. This is the deep intersphincteric space. This is also known as a posterior deep space. Between your internal anal sphincter anteriorly and puborectalis posteriorly. Whenever you are doing posterior fistulas, you have to eliminate the infection from this space. Otherwise, fistula do reoccur and persistence of fistula will take place. See the posterior deep intersphincteric space. This is the abscess. Fistula probe at the dentate line. You have to widely open this space. If you don't, I think causes for the recurrence of fistula, there is a talk and there is a discussion we have. This has to be widely opened. You have to eliminate the entire infection from this area in order to prevent the recurrences. There are other spaces, supralevator abscess above the levator ani, and apart from this deep perineal space and deep anterior space is also there. I'll show that. And this is the ischiorectal fossa. And the right side picture, why I have shown, while draining the ischiorectal abscess, don't aggressively break the loculi. You will be damaging the nerves and blood vessels. This is a new concept. The loculi, what you are thinking are the nerves and blood vessels and lymphatics. This is a deep anterior anal space.
Subcutaneous portion, superficial portion, deep portion. Here it is considered a superficial transverse.
This is the external anal sphincter, levator ani.
Transversely going here. This is a superficial here transverse.
That is a deep anterior anal space.
This is the deep portion of the
surgical importance of that anterior space is here the abscess spontaneously may rupture into the rectum, and differential diagnosis will think that it is a Bartholin's abscess. From the between the skin and your anocoxal ligament, this is a deep superficial postanal space. From here infection may spread to deep space and supralevator space. From here retrorectal space. This is the anatomy of your perineum. Just I want to show this. Imagine patient is in lithotomy position. The moment you open the skin, there will be fat followed by Colles fascia. The Colles fascia continues with the Daughter's fascia and Daughter's fascia with the Scarpa's fascia. And above, the perineal membrane attaches to the Colles fascia. What is the surgical importance of these fascias? The moment you open the Colles fascia, there is a perineal membrane, and above is the transverse perineal membrane. Deep to the perineal membrane, you will see the deep transverse perineal and spongiosus and cavernosus muscles. Anterior fistulas, the infection spread from the anal canal, from this Colles fascia through the Daughter's fascia toward the spinoscrotum. That is the reason you will develop the Fournier's gangrene. That is the reason you will have the external openings in the penile area and scrotum. And through the Scarpa's fascia, you will have the openings and inflammation into your anterior abdominal wall. From the Scarpa's fascia, it is continuous with the fascia lata in the thigh. So the infection may spread from the abdomen into the thigh. This is the surgical importance of knowing the anatomical pathways of spread of your infection.
You can see the external opening here.
This patient has the Fournier's gangrene. He was on the ventilator for
They
4 days.
involve the superficial perineal space, deep perineal space. Here the collis fascia will be there. Along the dartus fascia, collis fascia, and along the superficial transverse perineal membrane, they will reach the anterior abdominal wall, medial side of the thigh. Along from the collis fascia, dartus fascia, they involve.
I'm skipping that. So just summarize ABC of anorectum, anorectal ring, anorectal angle, you should maintain these, and bundles, external anal sphincter, 30% of anal resting pressure, and internal anal sphincter 55%. And cushions, they are essential for continence. That is the reason non-excisional trend of hemorrhoidopexis. And content sampling and capacity, these are very important function of the rectum. The capacity and compliance, it is the function where the intrarectal volume increases without increasing the pressure. Next slide, digital rectal. Can you show that? Digital, DRE. Only few slides, I'll finish fast. DRE. DRE, yes. Again, this is my favorite slide. There is a saying in the Sanskrit, Anguli evam pradhana yantrama gudavikare. So always, the finger is the cheap and most important digitometer God has given. You should always make use of it. If you don't do a proper rectal examination, if you fail to fit the finger, you may have to put the foot not into the patient, into the court of law and consumer forum. So let us see the history. One of the rewards in the medicine is the finding on the physical examination of the problem that was suspected on taking history, said by Gordon and Nivatwanks. The diagnosis of the rectal disease, the history was of little significant and everything depends upon the physical examination. Said by Lockhart Memory, your fistula probes are on the name of Lockhart Memory. He is king of rectum. Olden days he used to perform lot of rectal cancers. But truth is that most of the anorectal problems up to the sigmoid colon can be easily diagnosed by proper physical examination, said by Goliger. After taking the history, you will arrive at the diagnosis only 20%. If you do a physical examination combined with sigmoidoscopy, anoscopy, 90% of the diagnosis will be in your hand. The moment you receive the patient, after the consultation is made, you should take the detailed history, interview should be done by senior nurse, and then you can perform the simple questionnaires and simple examination. This is how to establish a rectal clinic.
The proctology examination room should be separate from your clinic, because if you have separate room, the patient will feel less embarrassed, less ashamed. Let us see how the examination room. It should be very well ventilated and it should be spacious, and it should be a stand for putting your IV, and also this can be used for the dual purpose. The patient can hang his underclothes. This is the examination table. This is nothing but your gynec labor room table, approximately 80 centimeters in height and length is 6 feet. The mattress length is about the 5.6 to 6 feet and width is 2.5 to 3 feet, and it is having the provision for lithotomy stirrups. So you can examine the patient in lithotomy position as well as in the left lateral position, and there is a provision. This is turp set where you can give the good positive pressure washing, and always you should have a very well LED light for examination the patient private parts. These are the various proctoscopes. To start with, this is Fidenol syringe. Initially the patient will feel discomfort, pain. I always push a little bit of xylocaine jelly. Never use the petroleum jelly, it causes irritation of the skin and mucosa. The moment after you inject 1 to 2 cc of the xylocaine jelly, start examining with little finger followed by index finger. This is a stainless steel proctoscope, various plastic proctoscope. This is a proctoscope for video proctoscopy. This is a proctoscope. This is a obturator. These are the disposable cylindrical proctoscope. These are your sigmoidoscopes. While sigmoidoscopy, you can push the air. This is a state-of-the-art modern video proctoscopy, where you can simultaneously examine the patient and show the video to the patient what is happening inside, what is there. There are piles, hemorrhoids, sharp fissures, hypertrophied anal papilla, and you can make a record of this and you can give the patient color print of this also. This is a software system. And coming to the dressing trolley, you should have a dressing trolley, as well as there should be a rack to keep all your dressing materials, towels or whole towels, everything. The approximate size of this one is 80 centimeters height, 60 and 45 centimeter length and width, and it should be well fitted with your baskets for gauze, dressing pad, jar, and saline irrigation, scissors, plasters, jelly, gloves, kidney trays, and there is a tray consisting of instruments, toothed forceps, non-toothed forceps, various things. And there is also a basket where you can keep all your instrument following the cleaning for drying purpose. Examination positions. Okay. The popularly practiced positions are left lateral, lithotomy, and knee chest position. Left lateral, we know that it is a Sims position. Sims is a urogynecologist. He used to perform the vesicourethral fistulas in this position. Many people may ask what is the best position. The best position is the one where the patient is less embarrassed, less ashamed, and surgeon is comfortable take the history. I think this is the best position. In this position, the trunk will be obliquely placed on the cot. The buttocks, there is a pillow below the buttock, and buttocks will be outside your table margin, and one side head will be other edge. Both the hips are flexed, both the knee joints are flexed. In original Sims position, both the knee joints were flexed. This is up to the surgeon. You can have the more flexion on the knee joint on the right side and less flexion on the left side. This is the position. This is best position for examining the female patient and elderly patient, and there will be a space for your assistants and guardian to stand when you are examining the minor child, and also there will be, you can take the history very well, and there can be space for your dressing table also. The only problem is you have to ask the assistant to stretch, or else I have made a certain modification where you can ask the patient to put a right hand and he can stretch himself. And lithotomy position in Japan, most of the female examinations is done by lithotomy position. The advantage is you can do a bimanual examination where the pelvic tumors, ovarian tumors, and pelvic collection you can examine. The knee chest position, the advantage of this position, the rectosigmoid angle will become straight and you can perform the sigmoidoscopy. While examining the patient, this is how you can stretch. Always ask the straining test. The rectal examination is incomplete without doing a straining test, and it is incomplete without examining your per-abdomen also. Straining test, there are the several ways. You can simply ask the patient to sit and ask him to do a strain, or while examining, ask him to bear down the pressure and strain. And you can put a gauge piece, and while removing the gauge piece, the prolapse, hemorrhoids or prolapsed rectal prolapse can be made out. Coming to digital rectal examination, there are the 3 steps. The first step where you will examine from the tip up to the distal crease. The second step from the distal crease up to the middle crease. The third step from the middle crease up to the proximal crease. In the first step, below the dentate line, we will examine. You can make out the fissures, hypertrophied anal papillus, internal anal sphincter, warts, and skin tags. In the second step, your finger will be just above the dentate line, where you can move the sideways, and here this is a step you have to look for your internal opening at the dentate line. Usually hemorrhoids are not palpable. In case they are thrombosed, you can feel the hemorrhoids, some villous adenomas, growths, polyps, rectal growths, distal rectal growths. This is the third step where you will palpate for the puborectalis. Puborectalis should be palpated laterally and posteriorly. And anteriorly, you should feel for the prostate and seminal vesicles. Prostate and seminal vesicles are best palpable in knee chest position, and posteriorly coccyx and sacrum. One point I want to highlight, anteriorly in case of females, you call something as pons asinorum. That means the uterus and cervix, they are felt as a normal only tumor-like thing. Always starts palpating the cervix, then go to the uterus. Pons asinorum is very important sign. Sometimes we will think that it is an abnormal sign. This is how you will feel posteriorly and laterally. This is just to squeeze test to know the tonicity of internal anal sphincter. After examination, always, thank you sir. No, I want to make this in a separate way, that routine anatomy is given, anatomical basis for surgeries.
Very nicely done. Ganga Shankar, you talked about everything about the anatomy of the surgical or anatomical anal canal. I want to ask you one question. Have you come across any of the literature? Because I have come down to the one slide where from the dentate line going above, the blood vessels are lying at different levels. Means 1 centimeter just away from the dentate, proximal to the dentate line, these blood vessels are submucosals. When you are going just above that, 2 centimeter, they are just below that. When you go up and up, these go just up to the muscular level. So this part of the picture is given in Doppler studies. So that actually that is the basis of DGHL. Or rather in two-tooth procedure also, when we talk about 2 centimeter and 4 centimeter. So, but have you come across any of the literature? Because this is a Doppler guided anatomical aspect. Anatomy seen by the Doppler. That this is at mucosal level, submucosal level, or just superficial to the muscles or deep to the muscles. So vessels. So have you come across in anatomical books? My question
Anatomical books, what they mentioned, vessels have extramural course, transmural course, and submucosal course. Only they have mentioned. Exact level they did not mention.
Yes.
And some of the vessels, they directly drop up to the cushion level, they pierces the muscle and directly supply the cushion. That is the reason failure rate. We may miss ligating those vessels.
Yes. And second important thing, all those positions for the parectal examinations, it is seen in western part of the world, that is lithotomy position is the better position for examining the patients of fistula.
Okay,
because one should know at which level the fistula is. So not left lateral position, but lithotomy position is better.
Even post-op washings and dressing, lithotomy is best.
Thank you so much. If any questions?